It's really my pleasure today to have a colleague of ours from at Johns Hopkins, who is, I believe, the only clinical chair at Johns Hopkins who's also a board certified informaticist. So it's a really special honor for us. And so Dr. Mohamed Rehman is the chair of the Department of Anesthesiology and Pain Medicine at Johns Hopkins All Children's Hospital. He holds an academic position as an anesthesiology, critical care, and pediatrics professor at the Johns Hopkins University School of Medicine. He is nationally renowned for his expertise in medical and clinical informatics, and he currently leads the perioperative health informatics unit as part of the health informatics core. And through evidence-based initiatives, this research unit aims to improve patient outcomes, enhance patient safety, and elevate the quality of care. His recent research endeavors center on the innovative human digital twin project that focuses on a paradigm shift from treatment to prevention and herd medicine to precision medicine. Dr. Rehman, thank you so much for joining us today.
We're going to go ahead and talk a little about my journey, what I've learned, and where we will be going, where we are today, and where we will be going in the future. So I got no conflicts of interest to disclose, and I changed the name of the topic. Can informatics and informaticians can help, or can they hurt a process? So what is clinical informatics? I'm sometimes confused what clinical informatics is, because in 2013, we started clinical informatics boards. Before that, there were a lot of us who were clinicians, data scientists. We worked as clinical informaticians. So what does a clinical informatics person do? If you look at the classic decision, it says studies, designs, develops, and implements electronic medical record. But if you look at what we really do as clinical informaticians, we do more than that. Sometimes we go on to say efficiency and effective use of data, use of large data sets. But what I think a clinical informatician is, the clinical informatician is a link who helps collaborate between leadership, data scientists, researchers, and IT teams. So we are folks who know a little of everything. We're jacks of all trade, master of none. We understand a little about data research, then we understand a little about leadership, but when we bring groups to collaborate, we are the gel that helps bring projects to fruition. So let me start with a story. We have a lot of people on this grand rounds. How many of us are depressed? How many of us are suicidal? We really don't know. This is a major problem in our society today. Can clinical informatics help? Here's a participants in one of our studies who was always responding to our surveys with depression and self-harm ideation. We tried to get help to this person. Did our study help or hurt this person? We'll close this at the end by saying what happened to Jane. So when we started looking at data, when a child comes to the hospital and we are looking at the child, and you tell the parents, here is what we think happened to the last 100 children. That parent doesn't care what happens to the last 100 children. They care about what is going to happen to their child. So this is an example where we looked at a single ventricle data set and created a calculator. It has 20 different variables. When you plug in the variables, it'll tell you what is the mortality for that child. I think that's where groups like Paul Naji's group, Kaiser's group can help, because you are moving away from generalized outcome statements to specific outcomes statements for that individual, that person, that family's child. So we want to move the paradigm from herd medicine, which is, okay, you take this blood pressure medication. Based on studies we have today on 10,000 people, it helps them. No, I don't care. What I care about it, is it going to help me or not? So we want to do a paradigm shift from herd medicine to precision medicine. And we also want to do a paradigm shift from treatment to prevention. When you are sick and you go to the doctor, they will tell you, oh, this is what happened. This is what we need to treat it with. We want to move to say, hey, you are going to get a heart attack if you don't care of yourself. And this heart attack is going to occur in the next 24, 48, 72 hours. That way, we can move the paradigm using the data we have, using the real-time opportunity we have, using the analytic platforms we have to a prevention mode rather than treatment mode. So if you look at the data we have today, we have a large amount of data. When I started doing informatics in 2010, each patient created about 40 megabits of data, sometimes 10 megabits of data per day. Today, each patient is producing, with the EMR high physiological data, 1 gigabit of data. Now think about it. If you look at the entire Hopkins, we're creating terabytes of data every day. So how can we utilize that to go and say, we can use this data to look and help patients to individualize care and to prevent from bad things from happening. So here's a slide I created 10 years ago. We use the data. We have to clean the data because a lot of the data we have today is garbage. If you don't clean the data, it's garbage in, garbage out. Then we convert data to information, information to knowledge and wisdom. So a lot of physicians, when we say, okay, I have this problem, let me talk to this specialist. For example, if I have an ICU issue, I can talk to Jim Fackler and say, Jim, I have this issue. What do you think I should do? If you look at Jim's brain, he has taken data over time, converted it to information, then to knowledge, and then to wisdom. So we're asking a senior physician because they have a mindset where they have wisdom and they can help. So this wisdom term is changing very rapidly today. We're calling it ChatGPT or any other large language model that's developed by Google, Facebook. So when you put in a question, what it's looking at is data converted to wisdom and giving you the answers. So if you're going to be working in medicine, if you're going to be doing informatics work, this is the holy grail. You can say, hey, Paul, give me $50,000. I want to do a project. At the end of the project, is it going to improve quality? Is it going to improve safety? By default, if you improve quality and safety, the cost of care goes down. So if you have a project, this is the holy grail of developing a project: cost, safety, and quality. If it does not do any of these three, and you go to leadership and say, I want to do this project, it's not going to improve quality, it's not going to improve safety, cost, nobody is going to approve it. On the other hand, if you say, I am doing this project, it's going to improve quality and improve safety, and by default, it's in the long run, it's going to reduce the cost of care, you're going to get buy-in. I showed this slide in Dubai recently, and a lot of the men were like, we didn't know this. This is culturally wrong. So over time, what I have learned from this slide is men think in a very simple, straightforward way, which is like statistics, univariate, multivariate. Women are very sophisticated thinkers. This has been shown by studies done in business. when you have women on your board, this decisions may take a little longer, but they are well thought out and stand the test of time. So I say that the way women think are more advanced, and they're thinking more in terms of networks and more in terms of machine learning. So from a personal standpoint, in the last 15 years, I have moved a lot from simple statistics to moving simple statistics into machine learning. So where does simple statistics stop and where does machine learning start? I like when we do a study to have a classic statistician and data scientist. The reason is the simple statistician will keep the data scientist honest to say, listen, you're making it complicated. This is a simple univariate, multivariate, or a run chart. Here is one of my first studies in informatics. We looked at children who underwent tonsils and adenoids. Tonsils and adenoids is a very common surgery that's done for children in the United States. If you look here, there were some children who just used 0.05 milligrams per kilogram of morphine. And then you have some children using 8 times, 10 times the dose. Is there any meaning to the madness? So we started working at this. So we had clinicians, we had informaticians, we had data scientists, we have people from genetics department. So we pooled this data. Luckily, we had about 3,000 children who had a clean data set of mainly using morphine and their genomics data set. And what we found was, if you were a high morphine user, you had a GWAS called TAOK3. We published this data in 2014, and a lot of physicians across this country said, this is phishing, this doesn't work, this is just nonsense. But luckily for us, this was reproduced in adults. And today we know if you have the GWAS, TAOK3, you're a high morphine user. So how does this apply? Think about the work that Kaiser and Paul Nagy are leading with OMAP. Fast forward 5 years, we have about 100 hospitals not only having the pharmacological data of what people are using, but also their genomic data. If we combine the data, we can find a lot of GWASs, and then we can help patients, because think about a patient with a TAOK3 coming to the hospital as in severe pain. We have given the usual dose, 2 times the dose, 3 times the dose, and people say, oh my God, this patient needs a lot of pain medication. But if you have their genomic data, you can say, this patient is a high morphine user based on genomics, and you would be preemptive in helping the patient rather than reactive and finally finding out this patient needs a lot of morphine and other medications to reduce pain. So is machine learning and clinical machine learning going to help us? There was a lot of hype, it's gone down, but we believe it will help. It will help if used appropriately. Big data by itself is useless, but if you clean the data and create algorithms, that will be helpful. You can say algorithms can be developed by simple math, simple statistics, machine learning, or you can use advanced LLMs. So what is the new team member on the clinical team? Jim wrote this with Winslow, telling that the new team member is algorithms. So when you're rounding on a medicine floor, or you go to see your doctor, they're going to look at data and say, you know what? This is a 50-year-old man who's come here, and based on his data, we don't see a PSA. They will recommend doing a PSA. So the new tool that's going to help us is algorithms and decision supports based on algorithms. So what is the holy grail of clinical informatics? Right information, right context, right time. But also to the right decision maker. If you give the right information, right context, right time to the wrong decision maker, it's not going to help. So this is the holy grail of clinical informatics. So here is an expert physician who is planning the discharge. So when your patient is admitted to the hospital, you have admissions, you have discharges, you have some amount of patients that are going to be readmitted, and that is unpreventable. But the big thing here is preventable readmissions. For example, if you have a patient who's come in for cancer, gets treatment, goes home, comes back in a week for treatment again for the second round, that is not a readmission. That is a unpreventable readmission. On the other hand, somebody comes in with a headache, you treat them, and you have made some diagnosis, you send them home, and they come back within 24, 48, 72 hours. That's a preventable readmission. And Medicare and Medicaid look at it very carefully because you can get dinged or fined if you are getting a huge bunch of preventable readmissions. So how did we look at resolving this issue? First, you got to always, when you have an issue, when you're trying to solve a problem, you need to whiteboard the problem. Forget about the software, forget about the hardware. Take a sheet of paper or go on a whiteboard and say, what is the problem? The problem here is readmission. What is the true prevalence? We really don't know. In pediatrics, there are numbers, but if you look at it, they're so variable. Can we prevent readmissions? Is this an indicator of quality? Absolutely. What's the best practice? Then you go on to say, what's the financial implication? The financial implication of solving this problem is pretty significant, and we need to resolve this. And is there room to improve from what we are doing today? Once you write this out, you say, yes, there is room to improve. Yes, it's going to improve the quality. Yes, it's got financial implications. Then you go on to say, what is the current practice? How can we change it? How can we reproduce it? And how can we continue to improve? In quality and safety, they call it the PDSA cycle, where you plan, do, survey, act. And the PDSA cycle keeps going forward, and every time you improve. So we looked at it and we came up with a machine learning model that Jeff and Luis built. And Jeff Gray is one of our data scientists. He does a phenomenal job. He was the lead on this. And what we found that the app, the data, the algorithm can help the physicians with making decisions on who not to send home and to prevent the readmissions at 72 hours. So we looked at it from how the hospitalists who are making decisions on the discharge and the readmission risk tool. They were both pretty similar, but the readmission risk tool was slightly better. So this is now implemented. So what happens is in the morning at 8 a.m., the clinician gets a list, green, yellow, red. We know if you send a green patient home, they're unlikely to bounce back. If you send a red patient home, they will bounce back. Yellow is where the physician input is important. A physician with the algorithm is better than a physician without the algorithm. So this was published, and this work continues to go on. So oversight dashboard. So one of the work that clinical informaticians do is help use data to improve the life of the leaders. If a leader has to come in the morning and look at this chart, they will finally get, okay, something is red, something yellow, something green. On the other hand, if you can present it in a simple way, you're going to reduce the cognitive load on the leader, and the leader can immediately put their finger on where they need to put their energy to help improve the hospital and improve the functioning of the hospital. Here is an example of changing this to this. So this one, anybody can see and see what's going on. So the Keystone dashboard. The Keystone dashboard is another dashboard that was created by the data scientist and the informatics team. The question was, when I look at my department, I need to know when I come in the hospital or evening when I'm going to sleep, is my department yellow, green, or red? So here is the Keystone dashboard. For people who live in Baltimore and Pennsylvania, they know the Keystone is the most important that holds the arch together. So it is built on data you get from the quality. It's built on quality of care, employee well-being, safety, efficiency, and the duty to report, where there is a issue relating to patients or personnel. It's a scale of 1 to 10, and you get the data sets from safety, quality, human resources, risk and regulatory, and from medical staff. This is how it initially started. This Keystone dashboard is, again, based on the PDSA cycle, can be scaled up, and the algorithms can get more sophisticated as it gets more data in. So here is all the data, and this is how it looks. For example, if you look at the anesthesia department, it's green. On the other hand, if I get a call from the data team, hey, your data, or if I look at it and say, the department trend changed from green to yellow, what happened? Then you know something has changed. For example, when 3 of my physicians left, one left because of family reasons, another left because he wanted to be in a place where it supported his lifestyle, and the third one left because I wanted to get rid of the person. Now, 3 physicians, 3 senior staff leaving in 6 months puts my department at yellow. So I have to explain that yellow is an anticipated yellow. On the other hand, if there are 3 yellows and the leadership asks me what happened, or people are leaving because they are unhappy with the department, that can bring about attention to a problem very early so that it can be helped resolved. The leadership pays close attention to this chart because you can prevent problems rather than treat major issues. So the human digital twin is something that I'm interested in, which is very close and dear to my heart. So it's based on my personal experience. So what happened is I moved from Penn to Hopkins in 2017. In 2018, there was a lot of problems in the hospital. Children were dying, and that's true because we had major changes in the heart center. And look at what's happening to my heart rate. You don't have to be a data scientist to say there is an issue. And then after I did some interventions, it came back. So next, what happens? If you look at, if this is your baseline heart rate here, and if it goes up, we all know something is wrong. If your sleep is here, it's supposed to be, I sleep normally about 6 hours, but if I start sleeping to about 4 hours, and then my heart rate, which is baseline at around 67 to 70, is now in the 75, 80 range, less sleep, higher heart rate, you have an issue. You know you got to come back to where you started. So what did I do? I understood there was a problem, I worked on it, and I got better. The other thing that I've used the digital twin, my own data, is to help me get over jet lag. Here's an example of me traveling to the East. I slept for 2 hours, 3 hours, and 3 hours. But then on my first day there, my sleep was good and back to baseline. So I have learned what is normal for me and how to bring my rhythm back to normal, sometimes using pharmacological intervention. Same thing, when I came back from East to West, look at the sleep for 2 days. It takes about 26 to 28 hours to get back. My sleep is abnormal. And then my first day back in Florida, my sleep is back to my baseline. So when I looked at the changes that had occurred in my heart rate, my sleep, my weight when there was stress, and then again, when I understood my own sleep rhythm and then I could manage it, then I said, maybe we can apply this to patients and to personnel. So we came up with a whiteboarding to understand how we could do that. We said we can collect all the data, use IOMT like a wearable, like Fitbit. We create a digital twin, and then we apply a layer of AI. If you are well, then you nudge to get better every month, every 6 months, every year. If you're sick, how can we bring you back to baseline quickly? So this was our concept of the digital twin. The digital twin, if you talk to one of my data scientists, Jeff, who has done a lot of that work for the airline industry, for the military, their concept is different. It is where you have data, you can simulate. So this is our concept. Is it true or wrong? I don't know. That could be a whole discussion for 1 hour. But this is how we are using it to improve the patients. If you're healthy, we want to nudge you to get better. If you're sick, we want to bring you back to the baseline as quickly as possible. So here is one of our proof of concept patients. This was a patient before we started using the Fitbit. We gave the Fitbit. The patient went through surgery and everything was corrected. And this is what happened. Normally after surgery, your hemoglobin goes up, your heart rate goes up. That's common sense. If you've got low hemoglobin, your heart rate is up. But in about 4 to 6 weeks to settle down, and see this patient settled down well, but at 8 to 10 weeks, the heart rate started going up again. The father called me and asked, hey, what would the reason be for this? And then we found out that the patient was using iron, but no folic acid. So was getting anemic again. Simple thing, we added folic acid, the patient did well. So it's a big concept called the human digital twin, but the concepts are very simple that you can use in your daily life every day. If your baseline heart rate is 50, and then you've been consistently sitting at 65 and not sleeping, you don't need Houston to tell you that you have a problem. Your common sense should tell you that there is a problem. Here is the spine. What we found was when you go for surgery, the spine surgeons tell you that you get better in 4 to 6 weeks. Some of the initial data that we looked at showed that some of our early recovery patients were back to, see, this is surgery, we're back to normal in 2 weeks. So if we wait on what the surgeon says, wait for 4 to 6 weeks, we may have lost a window of opportunity. So the goal is in the future, with the studies we do, we want to create individualized recovery pattern reports so that when a patient comes in for surgery, say you have an adult going in for heart surgery in Baltimore, we need to tell that patient, you're going to recover in 2-4 weeks, not a generalized statement that you're going to get better in 6 to 8 weeks. On the other hand, when we initially looked at this data, we saw some patients struggling at 6 to 8 weeks after surgery. So again, if we use what the surgeons say, 4 to 6 weeks, that one makes sense here because these patients will take a longer time. So when they come in for surgery and we say, hey, you're going to recover in 8 weeks, but we're going to help you with physical therapy, occupational therapy to recover at 6 weeks, then we have done good to these patients. But if you set up expectations that the patient cannot meet to get better in 4 to 6 weeks, we're setting expectations and we're setting up the patient to fail. And the sleep analysis is very similar. We are looking at sleep and we're going to see if the holy grail of the human digital twin is, if you're sleeping well, you're doing well. If you're not sleeping well, you're not doing well. So we're looking at sleep with different things. We are going to start a new study. We're going to look very early to see how the sleep is before and after. So we published this as a concept paper and then also as a feasibility. What we've seen is teenagers, if they use their Fitbit 50% of the time, we are doing well. But if you motivate them, then you may be able to get up to 70%. What we have seen in adults is motivated adults, personnel working, tend to use their Fitbit about 95% of the time, which is very good. So we are trying to look at data. We have some studies set up to understand feasibility, improving feasibility, get more data to help move the paradigm from treatment to prevention. We've done this with sickle cell patients. It was a small proof of concept that we're going to restart as a full-blown study. What we saw was this is the baseline when they're doing well. When they go into a crisis, they don't go from baseline to crisis right away. Each one is individualized. Some of them take 12 hours, some of them take 24 hours, some of them take 2 days. So if we have individualized sickle cell crises element data, then we can prevent it as soon as the patient starts moving towards a crisis rather than treat the crisis. So with the employees, we all know that there is a major problem with mental health, depression, anxiety in our healthcare. By 2030, we know that obesity is not going to be the number one health issue. The number one health issue by 2030 is going to be mental health. So we need to start getting ready. Data scientists, informaticians, clinicians can all work together to hopefully, we cannot change mental health from being the number one problem, but maybe we can reduce the curve. So if you don't have a healthy population, your cost of care goes up, the corporate wellness is not doing well, and in the end, it stresses the entire system. So what we did was we got a whole bunch of personnel in the perioperative domain. We wanted to see how we can understand the amount of stress. So we started a study, we started recruitment, we gave them a Fitbit, we gave them a psychological test, and we aggregated the data. But here is where our study got into trouble. Our study got into trouble because we started this around COVID, and then we asked this PHQ-9 question. The PHQ-9 question tells you if there's depression and if there is self-harm ideation. The problem is when you're doing a study and somebody reports self-harm or significant depression, what do? You have to get them help in 24 hours on the weekdays and 72 hours on the weekend. We did do it, but it stresses the system out significantly because when there is a report of self-harm or suicidal ideation or depression, this report has to be quickly de-identified by an honest broker, sent to the psychologist to say, yes, we have a problem, then somebody needs to call occupational health. And we need to provide help to that person. We are restarting this study without PHQ-9, and we're looking at simple scales like the PROMIS scales where we get the well-being data. We're also going to be looking at effects of call, time off, vacation on how it affects individuals and affects the groups. For the people who do a lot of data science, is in how we collected the data. We used a third party called Fitabase. They would aggregate the data, they would give it to us. We can also use the Fitabase platform to send messages for people who who are not using their Fitbit. Here's another how we aggregate the data for patients with the Fitbit. The initial part is the Fitbit data comes directly through Fitabase, then we have Epic data, so psychosocial data from surveys that they're doing. So coming back to Jane, so this was a person that I don't know who this person is, but we had a lot of reports of this one individual having depression and self-harm ideation. We did get help through occupational health, and initially the person did not take the help, but on the second attempt and the third attempt, the person did take help and get better. So think about this. In the entire Hopkins system, how many Janes we have who are depressed or contemplating self-harm. If we have data where we understand that this is going to be bad, or we can get them help, we can prevent bad things from happening. Not only that, we can create a healthier Hopkins so that the patients are, at the end of the day, we have a healthier workforce, the patients are going to do well. So these are new cohorts that we will be starting in the next 6 months. We have some initial lessons learned. We have some initial data. We are done with that. We have closed those studies. And now we're going to start new studies in the next 6 months from all the lessons we have learned. It takes a lot of people to do this work. And I'm lucky to have a good team. And clinical informatics, the informatician by himself or herself cannot do anything. It's a team sport. So we want to move herd medicine to precision medicine and treatment to prevention. I cannot end this talk without talking about the LLMs, ChatGPT. How is it going to help the physicians today? I'm going to give you an example of something we wrote about before ChatGPT became popular. This was a patient who came in for surgery, had many chronic illnesses. In the operating room, the patient became hypotensive, and they used a lot of drugs to treat the hypotension. I sit on this registry where people self-report. That's where this case came from. It's a PSO, and we looked at the case. They used every medication that the physicians have to control the hypotension. They could not. Finally, one of the surgical residents said, we packed the surgical site with gel foam. Everybody said, so what's that got to do with gel foam? They took the gel foam out, and the blood pressure and everything came back to normal. So then they sent this patient to the allergist for reviewing what allergy this is. When they asked the history, the patient had tingling sensation when he ate gummy bears. So gummy bears has porcine gelatin. Then they realized that this patient had allergy to porcine gelatin. That's why the gel foam they used in the operating room caused hypotension. So we put this case through multiple LLMs. Right off the bat, when it looked at the initial data set, it said, yes, this is an allergy. You need to treat the allergy. But it did not say gel foam. As soon as we added a line, tingling sensation from gummy bears, it gave 3 things that should not be used in the operating room. One was a gel foam. So large language models like ChatGPT and the others that are coming from Google, and Facebook, all these are going to help. They are going to change the way we do business. So I want to end this talk by saying informatics and AI will not replace doctors, but doctors with informatics and AI will replace doctors without AI and informatics. Thank you.
Well, thank you so much. That was really amazing, all the work that you've been doing and the impact you've made here at Hopkins. One thing that really struck me about this is that just how much there's so much data in the perioperative space from the anesthesia systems that you captured during the surgery, and how little of it appears in like the research. It seems like we're still collecting data at one institution at a time, and we need to figure out ways of standardizing it. I'm not aware of many standards around time series data, around how all the richness of the data we collect in the perioperative space that we then can then compile across multiple health systems. Is there efforts to start bringing this together? I only know of a couple of vendors who are even approaching this.
It's a very good question, Paul. One of the problems we have is a company does not want to work with another company. The two big companies are GE and Philips. Then you have Neon Corden. Each one's data set, especially taking the high physiological data that's captured in 300 hertz, 400 hertz, 500 hertz, and using the data, they don't have good systems. Like GE, it takes a long time to pull the data. Philips is the same thing. We have been working with Philips, and finally they came and said, yes, we resolved it. Let's go ahead and start. So we've been working on them, trying to get a contract. Then another person from Philips calls us and says, oh, I have a new solution to this. We said, wait a minute, we're talking to two people in Philips. So there is no standardized way of using high resolution data. I think that's an opportunity for a company that can be vendor agnostic and can use high resolution data. If somebody can solve that, you're going to be rich and retire next week. But it's not, it's very difficult and has not been done. There's small companies like SigBay and Etiometry that are trying to do this, but they're really, really small. You're talking about 10, 15 employees.
Yeah. And it's interesting. I mean, you look at the medical images, they're considered a legal record. The clinical notes are a legal record, you know, but the time series data is not. And so there's often not even good archiving of that data within a health system. I'm also wondering if there are other efforts for building, you know, for clinical registries across multiple perioperative environments for doing deep learning. It seems like it would be a big opportunity to discover new things for this space.
Absolutely, that's the holy grail. But how do we crack it? The reason is there is no standards on how to collect high resolution data. There's no standards for extracting high resolution data. And if you look at it, at all children's, Luis's group set up the high resolution data capture system about 4 years ago. We have 100 terabytes of data at about 450 hertz resolution. We don't know how to get the data out because it's a Philips data warehouse. They have a research module that we are close to signing a contract, pulling the data out. Their commercial product doesn't work. AWS says they can do it, but we really have not been able to do it. So we are sitting on 100 terabytes of data, but pulling it out and using it is, again, still a research entity, not a commercial entity.
And it sounds like, yeah, it's still an engineering exercise to be able to use that data for reproducibility. That's interesting. I do feel like that's probably an area that's going there. There's got to be efforts in place to start trying to do that, because we know we need to get multiple site data to do effective AI. So we have a couple questions from our audience. Really interested in your work on pediatric readmissions and complex care management. You wanted to know if there are specific published indicators for pediatric readmissions.
Yeah, there is. If you look at the article, essentially what you're trying to do is take data, convert that to knowledge and wisdom, and you weigh each variable. Initially, when you create a model like that, it's less than 50-50. It's worse than a flip of a coin. But as the model matures, the area under the curve gets better. So if you look at the paper that I showed came, it will show you how are the different variables we used. And that's just a start. As we keep making the model more mature, we're going to be getting more and more variables. So that's something that the OMOP may be a right place to do, Paul, because you have readmission data and you have quite a few variables. If you start with simple few variables and then the model keeps, it's going to be a very sophisticated model.
That's what I was thinking as well. I'm trying to look for where we can bring observational research standards into play here. So we have another question from one of our master's research students. His question is on your digital twin approach, and he wanted to talk about, let's see, what kind of cases that are best addressed by digital twin and what cases do not work for digital twin approaches.
Any case can work, but you first need to whiteboard. I think a lot of times what happens is we jump to the solution, but not go through the whole process. Let's say you're looking at your own sleep cycle. You can use a variable and get a good idea of where your sleep should be, how to improve it, how to get better. Any physiological data can be monitored and improved, but the more physiological data that goes in can help. You have to align that with psychological tests. That's where it gets a little difficult because now we are going into very specific data sets and we do not know what is, say, for example, one of the study participants said, my father died last week. What does that do to your physiological data? We don't know, but is everybody losing a parent react the same way? Not really, but we know each individual reacts differently. So the answer is you can use it anywhere, but you need to have a specific question that you're trying to answer.
Great. Excellent. That's great. Well, Mo, thank you again so much for giving today's grand rounds. And with that, we will conclude our activities. Thank you very much.
Thank you, Paul. Thank you, team. Thank you, everyone.